I'm dealing with an upper respiratory infection, so if I get hoarse, just bear with me.
Man, I'd have thought you'd have therapied yourself out of that problem by now.
Well, I've been trying. It was hard to breathe last night when I started the coughing spells.
Believe me, I know when it happens, it's hard.
All right, Tracy, you should be getting it in a second.
Okay, just waiting on it to come through. Okay, I have it posted. Let me just go verify that it is working. You good to go?
Hi, I'd like to call this meeting to order of the Respiratory Advisory Committee for the update on the rules and regs and other agenda items. Diane, would you do a roll call, please?
Yes. Raymond Peasney,
Present?
Sheila Guidry. Present.
Present.
Diana Mirandino, present. Michael Nolan,
Present.
present. Blake Nolan. Did he speak?
Yes, he said present.
Okay. James Lanahall. Brett Stafford,
Present.
Dr. Ugo. Okay, and then as my extras, I have Tracy Morrow, Patricia Bartholomew, Paula Pigford, Jacinta, Lauren Suduth, and Patricia Wilson. Okay,
So we do have a quorum.
yes, we have
we
a
do.
quorum.
And we verified that everybody can be seen and heard. And remember that for the public that's looking at this, if you have any public comment, please address them to publiccomment@lsbme.la.gov. And we will get those emails and read them into the record. Mr. Priesney, it's your meeting. I apologize for taking that time of yours.
Thank you, sir. At this time, I'd like to have a motion for us to deviate on the agenda to not to follow the format that's been set. Is that correct, Doctor?
You want to take a motion, take out of order, do the executive session first before you do the public session.
I'll make that motion.
Do I have a second?
Second.
Second from Brett. Is there any discussion? All in favor? Aye. All right. At this time, can we switch to executive session, please? Is there any public comment, Doctor?
There's no public comment at this time.
Right, just give us a second and I'll move everyone over. Someone just logged on as Comish Oggs. Can you state who you are, please?
Okay.
It's Dr.
Dr.
Aziz.
Ugo.
All right, he renamed himself. Thank you.
I just changed my name.
We're going to be going into executive session in a minute, Doctor.
No problem.
All right, if you see it come up on the right-hand side of your screen, just go ahead and select the blue button.
Oh, we didn't look at anybody.
What'd you say?
I just knew somebody was gonna hit the wrong one and leave the entire meeting.
No, I think we're
All
good.
right. Jacinda, we're back streaming.
Yes, sir, you are.
Okay. At this time, I'd like for Diana to read us the recommendation for case number 2018-928 and 2021-1369.
All right, was that 928 or 929, Raymond? I
I had
wrote it.
9. Maybe I wrote it down wrong. Let's
It's
Okay.
2018-928
8.
and 2021-1369.
I got it. Okay, the Respiratory Care Advisory Committee recommends, in reference to the case above, that the Department of Investigations get information from this individual's contract employers with an evaluation of the work after the contract was completed, of the employee's work after the contract was completed. We also recommend that the Department of Investigations ask the therapist about their current employment.
Okay, so that would be you, Miss Diana, making that motion, and you just need a second and a vote.
Do I have a second.
Second.
Brett, was that you that made the second?
Yes.
I'm sorry.
Yes, sir. That was me.
Okay. All right, at this time, we have a motion on the floor. We have a second. All in favor? Aye. Is anyone opposed? Okay, motion carries. Is there any public comment, Dr. Van?
No public comment, sir.
All right, so we can move on to our rules and regs. Do you want to give us a little insight, Doctor, how all the other groups are handling and how they're doing this before we get started?
Yes, I think that some groups are taking this and basically going through the rules presently section by section and saying what they want to change, what they want it to do, what they don't want it to do. Some have been more obsessive compulsive in keeping their own records. And, you know, we support anybody that wants to do that. It makes it easier for us. But I think the real key is if you get to a section, say that's fine, we just move on and keep working down through the whole set of rules until we address everything that's in there. And then the other side of the coin is, are there things that are not in there that you want to add? So there's going to be things to modify, things to add, and then the things that we want to remove. So again, we've found that going through it line by line or section by section seems to make people understand what's best to remove and modify. And then at the end, we decide what we're going to add and where we're going to put it. But that's how most everybody's doing it.
And also in the share cloud, I provided the last two documents that we worked on for the revisions, if anybody had a chance to look at that. So let's see. Are you gonna?
I'm going to bring that up I'll get it for you. Here's proposed changes. Raymond, can y'all see that one?
I don't see anything.
No,
Does
you're
anyone-
sharing your desktop at this point.
I'm sorry, I apologize. Please forgive me.
I'm gonna say it's really small.
How about now?
Yes.
All right.
So this was the 2019 proposal. It never got finalized. And then if you want to see the other proposal, I will pull that up. Okay, those are those are two different documents named the same as it turns out.
Yep.
So there they are. So how do you want to do this?
Did you? Anything on this? There we go. All right, well, we can start off. I don't know how much anybody's really looked over the rules and regs. You know, we did a in-depth review the last time, and these are some of the recommendations that we came up with.
And the
Do we
date,
want-
Raymond, is that on Friday, October 26, 2018? Is that the document you're
No,
No,
referring
it's-
2019, December 17th.
19? All right, just want
I
to
think
make
they're
sure.
both the same.
Hmm.
Is everybody good just reading this, or do we want to read it out? How do y'all want to handle that? So we can get some feedback on your perspective.
Well, I apologize. I can't find the 19 in my
It's on
room.
the screen.
Yeah. Okay, let's see. I hate getting no, can't see, can't hear.
Mike, it
You're
was
a bit-
sent out. It was sent out, Mike.
Also, I can't remember.
All right, we're being live streamed, so be cautious of what you say.
Michael, it's on the screen.
I'm okay with just reading it.
Yeah.
Okay.
So Raymond, because I haven't been to nationals in a while, and haven't really talked to Lori Tinkler, we know the exam is going to change and they're going to get rid of the clinical simulations exam, which I don't think that was anywhere in our language.
Think so.
So that first statement, the registered respiratory therapist would be the one who completed the registered respiratory therapy credentialing exam. They hadn't changed the name on any of that, right?
Correct.
Okay, so that's still good. Okay.
Yeah, can you explain this one? Need a statement that they would have to cover an individual who is in an operating room monitoring neurological processes during spinal surgery. Wouldn't that be a registered respiratory therapist?
Trying to figure out why we put that down there, because it says institution of any type of physiologic monitoring applicable to respiratory care, including but not limited to cardiopulmonary and neurological processes related to such disease. And maybe we did that because it doesn't technically have to be a respiratory care person. There were institutions that were training individuals to go back into the neurological suite when they do spinal surgeries. Basically, they're poking them in the toe and watching them for nerve transmission. And they were using respiratory therapists, but my understanding is they did the training. So, I mean, they might could even train an LPN to do this. I don't know. I've slept since we wrote that, but I do know that there are respiratory care individuals that are working with OR and orthopedics on spinal surgeries.
Is that something that is a part of respiratory therapy school itself?
No, they were trained with the facility. And Dr. Ugo, I'm going to be very honest with you. I'm not even going to tell you that this individual or individuals, because I knew 2 or 3 of them still hold a respiratory care license.
I'm almost inclined to take out that neurological processes part during spinal surgery. That's very, very specific. And it,
Specific.
yeah, and it might prove to be problematic in the future.
Yeah. In the current language, I'm sorry, sir.
No, go ahead, sir. Go ahead.
In the current language on letter C, it says institution of any type of physiological monitoring applicable to respiratory care, including but not limited to cardiopulmonary and neurological processes related to such diseases.
I would just say cardiopulmonary and take the neurological. The name, it's in the name. You're a respiratory therapist, not a respiratory neurological therapist.
Go back up. A little bit further down. Right there, C. C. Come on down to C. Right there.
Institution of any type of physiologic monitoring applicable to respiratory care, including but not limited to cardiopulmonary and neurologic processes. Yes, that neurologic processes make me, because then we'll just keep adding stuff to that. In 5 years' time, it will be musculoskeletal processes and then kidney processes. I don't know if I'm being facetious, but cardiopulmonary care is what a respiratory therapist is primarily supposed to be doing. The neurological one seems like an extra lanyard that if a particular institution wants to go down that road, that's on them, really. I don't know if if that makes sense.
I agree with you, Doc. I don't know why we need to, if they're doing OTJ for EEGs or things like that, I don't know that that's necessarily our purview to look at that if it doesn't violate any rules specific to that procedure.
Right. If it's not something that you're being trained in school, then it shouldn't be something that we should incorporate into our guidelines and expectation, such that a new graduate can't go into it and have to start learning about this all over again, like learning something new. So if a new graduate went to this institution and say, yeah, you're going to be on the off shift for the person currently doing it, they would not be able to do that.
Yeah. You're licensed, you get to do it.
Yeah. Right. But as it stands in our current definition, they should be.
So we're saying we're going to take out neurological?
I'm recommending that we take out neurological and just leave it as limited to cardiopulmonary processes related to such diseases.
But would that neurological include EEGs?
Well, I was going to say, that's what I think you got to leave neurological in, because we do sleep studies. And while we're looking for obstructive sleep disorder, they're also monitoring for restless leg or anything else they see. And so I don't think you can take neurological out. I mean, Dr. Ugo, that one has been there
a long time.
for a very long time.
I agree. And there's a lot of respiratory therapy people and places that have oversight for all of that. Over the sleep lab, usually it's a respiratory therapist that's dealing with that. When under me, I'm director of respiratory and neurodiagnostics. So all EEG stuff.
I agree with you. I would say that sleep is very much process related to such diseases. Like that, I feel like that line right there encompasses sleep.
Yeah, well, cardiopulmonary, but what if he's got an EEG tech that he has trained and they're going up to look at a seizure disorder? I mean, when the EEG tech gets their order, it doesn't get discriminated into, is it sleep only or is it something else? And we're not talking about a lot of individuals out there, but it is covered, and the individual has been trained, not necessarily by a respiratory therapy program, but they have been trained. And the other name that I couldn't remember just a second ago, the other person that was doing the spinal, they were called inter-op monitors. And they had the basic physiologic knowledge, if you will, but there was advanced training within the hospital facility to take an individual that already had a foundation and build on it. So, and I guess what I'm trying to, just because I see neurological processes, I'm not going to go sign up for that, because I'm going to tell you, I haven't been trained in that. But if Raymond hired me and said part of my training was going to be sleep studies and EEGs, then he's going to have to train me with sleep studies and EEGs, if that's what he's covering, or if that's what Brett Stafford is covering.
Can we,
Dr. Van first.
oh, I'm sorry.
Oh, I'll yield to Ms. Wilton and then I'll comment after her.
So I think if you want to, this is the problem with itemizing things. If you want to keep C or keep the concept of C, meaning as long as it's something at least reasonably related to the practice of respiratory therapy for which you have been trained and credentialed, you can say that, but as this definition applies, it does not put anything on a physician or a practitioner to have been duly trained and et cetera. So I would, at the very least, I would put something in an overarching statement that says, for which they have been trained and credentialed or something like that.
And I would add that I don't think, and maybe Dina, you can tell us, are any programs teaching these technologies to respiratory therapists? There is no licensing, to my knowledge, of EEG technicians, and I don't really want to get in that business unless you think we absolutely have to, and we license respiratory therapists. And if this is something that is done by unlicensed people, anybody can do it, but maybe Lauren has a better idea.
Well,
Go ahead, Ms. Ann.
I was just going to say, we had talked about with our baccalaureate program up here doing an extra year for sleep credentialing. And what we realized is we don't have to do that, because our therapist, even our associate degree therapist, are able to come out and under this licensure law, which has been in place for years because there were people that weren't even licensed to do sleep, were being hired to do the work in the neurological centers. And again, the majority of it was when obstructive sleep apnea, really took off big, and they were putting up the facilities on every other corner. And I would still say the one sleep institution that I'm more familiar with in town here, I would bet you 80, if not 90% of her employees are respiratory care practitioners. Okay, you don't find many out there doing just sleep. And so there are some that have been doing this, for years. And again, when you get the order and I go in, you might think you're looking for sleep apnea, but I might end up with restless leg or some other type of sleep dysfunction. Am I treating it? No, there's a physician. Am I reading? There's training for those individuals to go back and read the sleep studies. Does that mean they're prescribing? No, the physician still has to go back, but they're pointing out the inconsistencies or the abnormalities on the sleep studies for these physicians to go back and make a diagnosis and write a prescription.
Let me ask this, are all
let's see,
sleep
Lauren.
studies read by physicians?
Yes.
What?
Are all sleep studies read by physicians?
Well, let me put it like this. Mine was because I got a bill from somebody I never saw.
Mine is as
Yeah,
well.
so they can be scored by an RPSGT or an SDS, Dr. Van, but I believe per CMS, the final read has to be by a physician.
Yes.
And I
Okay.
certainly think that's what our polysomnography advisory committee folks think is happening.
Okay. Lauren, you had your hand up and I apologize.
Oh, no, I just had more of a procedural request. If we're making changes in the document, can I share my screen or have somebody do like a track
You can share your
changes?
screen. I'll stop sharing and you can share yours. Go ahead.
That way we can make the changes in the document and not have to go back, and we can get y'all's actual desires on it. So if we want to make any changes to that, let me know what to write and we'll write it. But that was all.
I guess I just want to make sure I'm understanding this correctly. There are respiratory therapists that are doing EEGs. Is that what I'm understanding?
Correct.
Gotcha. But in respiratory therapy school, you're not being trained to do EEGs. Is that correct?
I'm not going to tell you that's not happening. My school's not doing it, but there are programs that have a sleep component to it.
Gotcha.
My particular
Well,
program does not.
Well, let's take the non-sleep related EEGs.
Right.
The neurologist has a patient with a seizure disorder and orders an EEG. Are the respiratory therapists trained to do that EEG?
Right. And I think that's what I wanted to get to.
Not in
They're
school,
doing
to my
EEGs, they
knowledge,
should.
no, that would be an OTJ function.
So that's not a core competency. So I think
Is
I
the
would,
sleep track that COARC can add on, does that include EEG or is it just in relation to sleep? I mean, like standalone EEG. It's been so long, I can't remember.
Oh, it's a separate accreditation process, Blake.
Yeah, I know. I had looked at it for South Arc when I was there, but I can't remember. Does it cover standalone EEG or only in the context of a sleep study? I honestly can't remember how that's broken down on their matrix.
Now you're going to make me
Yeah, I
lie.
know. That's
We
too
can
much
go
for me.
back but between a couple of us, we can investigate this.
Yeah,
I think
can
the
look at-
things that we have to consider here is yes, we're looking at respiratory care practitioners in the state of Louisiana. B, we're looking at those that are trained, but we're also looking at what the American Association of Respiratory Care looks at in regards to job responsibilities, whether a hospital has it up underneath them or whether it doesn't have it up underneath them. And then the training facilities, such as COARC, who also regulates the sleep components. Again, I realize we're talking about, safety issues here, but there's no way that Stafford or Peasone's going to hire me and go, okay, go do this sleep study without knowing I'm competent in that area. I mean, there's just, it's not going to happen.
all right, well, Gina, I think, and then what you're raising is an important issue. We need to get what those standards are before we can make this decision.
Okay. So let me do some more research with the AARC, the MBRC, our COARC, and standards. And again, and I'm kind of addressing Dr. Ugo, while the state of Louisiana, this is the other thing we were trying to look at while we were doing these rules and regs the first time around, is while the state of Louisiana may not be what is considered on the cutting edge of respiratory therapy, the last thing we want to do is take out neurological processes and then 2 months from now, there's a whole shift and then we're dead in the water here. We tend to run behind the times with some of the other, but let me check with AARC standards, NBRC, and COARC.
I agree. I don't think we can take this word out. It's been there a long time. We've been doing EEGs, sleep studies. Now some programs have it as a component. Not every school, but even if some have it, we have to cover them, you know. And as more and more schools, probably I would think, bring it on as a component. We want to have it covered in here. We don't want to not cover it and then say, oh my goodness, it's not covered. And so y'all can't do it.
Okay.
I do agree with the new verbiage that we had with the operating room monitoring neurological processes during spinal surgery. I have no problem with taking that out and leaving that out but I don't think we should take out the word neurological as it has been for many years.
I think we need to do a little bit more research. I'm trying something in my mind, and I'm trying to Google it as we speak. Is Holy Cross College in New Orleans? They have some type of EEG program and respiratory, if I'm not mistaken. So I can do a little homework on that before next meeting as well, and get that out to the committee members.
Well, and I guess my question would be, how does this affect, those EEG techs that are not therapists?
Right. And I also
because I would say that's probably the majority.
right. I also don't want it to be that respiratory therapists are the catch-all for jobs or things that the therapist will do it, right? I can see that becoming a thing. And I don't know if I'm overthinking that, but I could see that being something where, well, the therapist will just do it, right? So and then neurology can be a very, as we've just experienced in this conversation, neurology itself is a very diverse topic. We went from spinal things in pediatric population to sleep. Where does a respiratory therapist fall in line with that? So I completely understand leaving the neurology in there. I just want us to be I guess I just want it to be a little bit more refined so that it's not just something that, hey, you're supposed to be able to do this. Why aren't you doing it? Why weren't you trained to do it? That kind of thing. I don't know.
Yeah, do we really want a case number where somebody's doing deep brain stimulation?
Right, because it says neurology, but and therapists already in the hospital do a lot of catch-all jobs, right? So the respiratory therapists are out here doing like a lot of things that are, there are positions for those things. So you can imagine how EEG techs then are no longer hired because, well, respiratory therapists do EEG. Why don't we just have them do all of that?
All right, Ms. Wilton.
I'll just say one more thing and then I won't say anything else. But I think what you're trying to nail down here is what is the scope, the generally accepted scope of practice of a respiratory therapist, and how far does it intrude into other disciplines and other areas of practice? And so I think that's probably what, when you and Miss Diana do the research and look at what the national organizations and so forth and the credentialing organizations are doing, you might get a better handle on that. But when you leave things open-ended, it's difficult to discipline somebody for practicing outside their scope of practice. Then you're just looking at malpractice versus unauthorized practice. So that's the only reason why you would want to be relatively
Defined.
clear. Yes.
Right. Yeah, exactly. And then we should, at some point, do we still call you a respiratory therapist if you're doing all of these things? Do you have, is the job a different job? But
We want your job, Dr. Hugo.
I try to figure it out every day.
So I'll make a motion that we put a hold on that section till next time. Till we do further investigation.
I second
Okay.
that. And guys, for notes here, do I need to be writing? I mean, she's making the changes. I'm making myself notes about who's doing research here and there. And is there any other notes that I need to be taking here for this meeting?
Not at this point.
Thank you.
All righty, so let's move on on our document. We have about 15 minutes left to this meeting. Let's see, can we put the other one back up?
Yeah, give me a second if you
Here,
was-
I can change it.
Okay.
So 1 second.
Proposed changes document.
Yeah, I'll just pull up wait 2 seconds. Zoom. Can y'all see?
No,
Is it too small?
yes.
Too small.
Okay. So I have them both up on my computer right now.
Let me bring it up. Just Lauren, I got it ready to go.
Oh, you got it? Okay.
Can y'all see that?
Yes.
Yes.
Yes, thank you.
This would be
This
H.
thing would be in order, the administration of humidity and aerosol therapy and nasal therapy inclusive, but not limited to naloxone, Beckinase, Flonase, et cetera. Want to keep that in? Want to add that?
Yeah. Yes.
Okay. Starting of intravenous lines. The practice of respiratory therapy to include peripherally inserted central catheter with proper code of protocol for evaluation of line placement post placement under the order of a physician. So is that to mean that they order the x-ray or the physician orders the x-ray?
For the evaluation, you mean?
Because when you float that catheter in, you got to check placement, an x-ray needs to be done. And I'm not sure we have the authorization to say respiratory therapist should order an x-ray. That should be something that's done on the order of a physician.
Could the
That's what
physicians
trying
not
to say, we
establish
should
a
clarify.
protocol within their facility?
Yeah, Brett. I mean, Blake, that's what I was thinking. It was almost like, if I intubated a baby in the NICU, protocol was anytime a tube was placed, an x-ray had to be ordered.
Right.
So it was protocol that got done.
Yeah.
I mean, Diana looked at the nurse and said, I got the tube in, call x-ray. But that wasn't Diana Marandino going, oh, I don't like my breath sounds, give me an x-ray.
Yeah, if you want to get technical, your medical director of your department ordered that x-ray.
That's what I want to make sure we're clear.
Yeah.
Okay, we're gonna reword that.
Yeah, we'll reword it to a proper facility protocol that includes a medical director's order.
And there's no problem with the State Board of Nursing regarding starting of intravenous lines. I realize we're doing it. But,
No,
No,
okay,
and add instruction on equipment for the diagnosis of therapeutic treatment for ventilator support or ventilator disease management. They're trying to address the RT must instruct patient in the setup and use of equipment. The delivery personnel from DME companies cannot instruct. And we've been following that pretty much along the way.
yeah.
Real question is, okay, we have in other areas, particularly in polysomes with this instruction, talked about a unique instructor permit that just does instruction. I'm not sure that you want to add it, but I want you to know that that is something that's starting to come out. Polysomes are telling us that it's happening, but polysomes do not believe they should be licensed. If you don't believe they should be licensed, that's fine with us too. I just want you to know about it and not get blindsided down the road.
okay, so my question is this, unique instructor permit. So if this is something that comes to play and I have a unique instructor permit, who's that coming from and who is that regulated by? And then if I get out there and I'm instructing mechanical ventilation or ventilatory support, and I tell the patient the wrong thing and things go south, who gets the backlash for that? The DME company?
Well, here's the thing. If you make it so that only RTs can do this, then we don't have to worry about it. And we'll stick to our guns. If you want to add it, we're going to have to add a new light. It's all going to have to be approved by the state to let it happen. It's a permit that we issue, and the permittee and their employer would be the ones that get involved. And the liability would be theirs. But
Yeah,
if you,
and I don't see a DME being able to fully instruct someone, you know, in the ins and out of mechanical ventilation.
and I'm perfectly happy with that
Yeah.
if it's my ventilator you're adjusting. I just want to tell you what the world out there is thinking, so you'll get, we always talk about what's going on in the world. And I think you need to
Yeah,
know
because
that.
there's bound to be some company who doesn't want to hire RRTs. They want to pay
Right.
somebody $15 an hour to do it. And so they'll push for that. You're right. So yeah, I think it's important we establish, no, this needs to be a function of a respiratory therapist.
Fine. I'm comfortable. We are already down to section 2507.
I have a question. Okay, so someone on your end, Dr. Van, is editing the changes we're making?
I'm making notes and Lauren is making notes.
Oh, so she's not doing it live while we're doing it.
If you want to
No,
go back to the,
I'm trying to keep up and make the changes on the,
she's
on
doing
this little
it as we do it, just like we're doing. If you want to go back to her document, we can.
Because this is my problem. Okay, the edits that we're making, whenever they come back out at the end, I won't remember the wording that we did, like say on,
Okay, well, what's going to happen is there'll be, what we will ultimately see is a lined out section and new language in red.
okay,
So you'll see new language in red.
okay.
Now, what we can do, since we just about finished today anyway, Lauren and I can get together on the rest of this proposed change document and go back in and put them in a different color in the context of the whole rule pages that we looked at earlier. So when we get to them, you can see what you wanted to add, and then we can make it change any way we want.
I was just about to say the exact same thing. If y'all, this previous 2018 version, if this is what y'all want, I'll just go ahead and make these changes in the big document, and then we'll just go through that document and pick the exact wording and go through that document step by step. That way we can be making the changes together. Because there's like nuance, like obviously I'm not a respiratory therapist, so like y'all know all the nuance, and I don't want to. I want to use y'all's specific wording on this, you know? So assuming y'all reviewed 2018 generally, I'll incorporate those changes, and at the next meeting, we can review those changes and like specify them out.
And basically what Lauren and I will do is anything that's in bold is what will make the changes to the document that we're editing. And they'll be in red so you can see them, and then we'll go from there. And it might just be easier if you want to, say
Have
that's
one working document. Yeah.
yeah,
just
one working document.
one master working document. And also, there'll be some wordsmithing too. It won't, I mean, for the working document, we can include some of this stuff verbatim, but when we go to finalize it, there'll be some wordsmithing.
Okay, I understand. It's just that, I can't write as fast as we're making the changes like on
No,
I.
let me say this to you. What will happen is next time you'll see an edited document, which we can edit again and again. And every time we edit it, we'll give you'll see it the next time, ready to go.
See,
Okay,
that's what we're doing, what I was doing right now. Like the additions are blue, strikeouts are in red.
okay.
And like on my, you obviously can't see my whole screen, but on my screen, I have the other document listed on the other side. But yeah.
All right.
Okay.
Leave that,
Thank you.
leave that page right where it is. I have a question before.
Yeah.
I know we were supposed to move on to the next section, but I want to go back still while we're in this section. On letter L, number I,
Mm-hmm.
drawing of arterial venous and capillary. I got challenged by my Joint Commission inspector when she was here just a couple of months ago. Unless I'm missing it somewheres, there's nowhere that says that we analyze the sample.
Oh, so you want drawing and analysis
Yeah,
instead of for analysis?
Yeah, there is a linguistic implication that somebody else would be doing the analyzing there. I see what they
Right.
mean.
Right.
I like that too, maybe adding that in there as well.
Mhm.
Okay.
Never had anybody call me on that, but I mean, yeah, I can see it.
I did.
Wait, what's the issue? What happened? I'm confused now.
When I had my Joint Commission inspection a couple of months ago, she read through our Practice Act. She was very thorough. And she says, I don't see where you can analyze, a respiratory therapist can analyze these samples on a blood gas analyzer. It says that we're only drawing, what is the word? Let's see. Drawing of arterial venous.
It's right here on the screen.
Mhm.
To be performed. Didn't we put a position statement out on that a few years back?
Yeah, there's an old
I
white
think so,
paper.
yeah.
It's related to the electrolyte analysis. I'm trying to remember.
I thought we had something there, but I'm like you. Yeah, I think that's definitely something we want to be sure that we include in any regulation changes.
Well, and I like the second part of the verbiage, to be performed on blood gas instrumentation, because the available test panels are changing.
And that's why we went to that language, because of all
Yeah.
the
Like I'm
panel
about to start
changes.
ionized magnesium. It's just, there's always going to be something new.
Okay.
Dr. Uzo, Hugo, I still see you have confusion. Do you have you want to comment any or further explanation or anything?
Oh no, I just don't. I feel like by definition, you're drawing and you're also analyzing. It's all the same. I think clinically in practice, drawing and analysis go hand in hand. But I don't know if that I don't know.
Semantically, the way it read was drawing it for analysis, which implies or could imply that somebody else was going to do the analysis. So if you make it drawing and analysis, then it's clear that one person, the RT, is going to do that.
Got you. Okay.
It's like when
I
a nurse draws a specimen, they can analyze, they can do wave stuff like glucose monitoring, but they can't do a cell differential through a microscope, at least not in a way that's CMS compliant.
guess I'm just used to y'all doing that anyway,
Yeah,
drawing
we
and
do.
analysis. It's semantics, and it seems like an odd hill for the Jacob person to be particular about. But anyway, I
And
apologize.
it was a lab person.
No. It was an amazing survey, Doctor. I had to fly back from Orlando to come back to this inspection.
You're better than me, Raymond. I wouldn't have.
Raymond, I need to go. Can we stop here?
Yeah, no, we're at our time. We have a minute left. I want to thank everybody for getting on the call, and we'll continue our work at the next meeting. Dr. Van, is there any public comment?
There's no public comment at this time.
All right, well,
every-
everybody.
Well, I
I'm
was just
sorry.
gonna say, did everyone see Mike's new email address in the chat? He had put in the chat that he has a new email address.
Yes, I got it.
Okay.
All righty, thank everyone.
All right,
Thank
thanks. everyone.
you.
Strong work, guys. Thank you. Have a great day.
Thank you, everybody. We'll get another
Thank
meeting
y'all.
scheduled soon.
Appreciate it. Bye.
All right.
You have a good one.
Miss Wilton, still there? Gone. I'll get her.